I know that we had a wonderful session of laser and aesthetics. So back down to earth. And it's my task to talk about dermatophytosis. And believe me, superficial dermatophytosis are probably going to be the number one problem going to be seen by dermatologists, hands down. You can forget the rest of this conference. It is dermatophytosis which is going to challenge you. And this is a fact. This is the fact of life. And therefore, it's really a pleasure for me to say that I got this opportunity thanks to Radav and to Jamjum Pharmacy. Of course, this is going to be a commercial talk on luliconazole, but I will open my remarks by saying that it's a wonderful picture. You can see a caterpillar forming and then the butterfly coming out. Evolution at play. And we all know Charles Darwin and the theory of evolution, and we know that it's by a process of natural selection. And the fungi seem to be very smart at it. A geophilic fungus becomes an anthropophilic fungus. In between, it's a zoophilic fungus. So which part is geophilic? When does it become zoophilic? And when does it become anthropophilic? It's really a fascinating journey. And I would say that this evolution has been so rapid that fungi as a whole have proved that they are very intelligent. They are more intelligent than human beings. And they know exactly how to avoid all our medications. And they seem to learn what we as human beings do. After all, life wants to survive. And when a dermatophyte comes on our skin, it doesn't want to go away. And it knows that we are going to use a topical fungal cream, probably a fixed dose combination containing a steroid. And it has learned how to evade it. And we know that multi-drug resistant dermatophytosis is a fact of life. And it has posed probably the biggest challenge for dermatologists that you may ever think of. I was actually very lucky. Dr. Shyam Verma and Professor Petronyanov helped me actually participate in a study, and Silky Urli's PhD thesis, 70 of my samples from my clinic were sent. And I won't comment on it too much because my task today is to talk about the prevalence and unmet needs, luliconazole overview, the MIC studies, the clinical studies, the patient counseling, and why luliconazole. So my task today is to talk about luliconazole, and I would say that, again, when you talk about the burden, 20 to 25% of human population is probably affected by dermatophytosis. You forget the rest of the conditions. It is dermatophytosis, hands down, which poses the biggest problem. And we are not talking like psoriasis about 3% and 1% prevalence. We are talking about 25% of the human population being affected. We are talking about billions of people. And it continues to rise. And this statistics doesn't make too much sense. It says that nearly 40 to 48% of people in Asian and Middle East countries are going to develop it at some point of time or other. Believe me, it's an infection. And as an infection, there are three things: the agent, the host, and the environment. We all know that we are in global warming. It's not going to be just Asia and Middle East. The fungus has touched the Americas, and it has spread worldwide. So global warming has resulted in a change in our environment to such an extent that it has permitted the fungus to evolve. The agent is no longer Trichophyton rubrum. It's actually called Trichophyton indoteinae. Mycologists are very funny people. They keep changing the names frequently, and the same fungus can be called by different names depending on when exactly it is called. Therefore, most of the studies are something that we need to be looking at with a pinch of salt. Is it burdensome? It's a huge burden because of many reasons. One, it spreads to the entire family. If one person has it, it wasn't so during the rubrum era, but now, if one person gets a dermatophytosis in the family, everybody gets it. And if it's a labor camp, if a few people get it, everybody gets it. So it's no longer confined to an individual, but it rapidly spreads. Itching, smell, stigmatization, the frustration that we are not able to cure it, these are all realities of life. There are multiple factors and multiple unmet needs. We know that there are any number of topical antifungals with us, but none of them seem to be working well any longer because of multiple reasons. Prolonged treatment duration, non-compliance, poor compliance, and small number of dermatophytes being able to survive, and also relapse rate, which seems to be very, very common. So we need new antifungals, and we need new antifungals because we have used a lot of azoles, and topical azoles have been with us for quite a long time, and many of the older azoles no longer seem to be working or need to be given for a much longer time. It's the same story, the agent, the host, and the environment. And researchers actually aim to discover new antifungals which are more potent and less drug sensitivity. So we know that the management of dermatophytosis has both pharmacological and non-pharmacological aspects, and we know that we already have a large number of tools with us, and these are the characteristics of an ideal topical antifungal agent. Broad spectrum of activity, efficacy at low concentration, fungicidal activity, keratinophilic, lipophilic effects, high mycological and clinical cure rate, lack of development of fungal resistance, low relapse rate, low incidence of adverse events. So let me get into my core topic, introduction of luliconazole. It's a 1% cream, and it has been approved by FDA in November 2013 for the treatment of interdigital tinea pedis, tinea cruris, and tinea corporis. So it has been there in India and Japan for much longer time, but we got this in UAE recently, and it has actually a broad spectrum activity against a variety of etiological fungal diseases. There was an interesting write-up in Dermatology World about Trichophyton indotineae, and in the conclusion, it mentioned luliconazole along with itraconazole as the recommendations for treatment. And it has a unique structure, and this unique structure enables it to have a strong clinical antifungal activity because of two factors: strong in vitro antifungal or fungicidal effect, and a favorable pharmacokinetic property, its ability to stay in the skin and reach a very high level of MFC. We'll come to that soon. So topical antifungals with potent anti-inflammatory action are the need of the hour. We are all fed up with the steroid antifungal combinations, and we know that the fungi are very smart and they adapted to it so much, and that is one of the primary reasons why we are facing drug resistance very frequently nowadays. And luliconazole has demonstrated strong steroid-like anti-inflammatory properties. And even though it's an azole, we all know that azoles are supposed to be fungistatic, but this has proven fungicidal against the Trichophyton species. And again, a pinch of salt. What do you mean by Trichophyton species? That's a crazy thing to say. The Trichophyton group of organisms is a huge group. Which of them is Trichophyton mentagrophytos, which is interdigital, and which is Trichophyton indotineae? God only knows. Even many of the culture tests and biochemical tests can't prove it. You need actually genomic studies and advanced studies to prove it. How does it act? It acts by inhibition of lanosterol. Basically, we know how azole works. Interesting point, 8,000-fold or greater than the minimum fungicidal concentration can be demonstrated on the skin. So you can see the MFC on the skin is so good. What about the minimal inhibitory concentration? We all know interesting discussions are there. Does an in vitro MIC correlate with the in vivo activity? Probably no. But still, the lowest MIC, that is luliconazole, has shown that it has the highest antifungal activity against the Trichophyton species. And it is the Trichophyton species that we are primarily interested in nowadays. Most of the other fungi have actually been replaced by this group. And you can see here that when you look at the various fungi, rubrum, mentagrophytos, strontiorans. Luliconazole has proven to have the MIC which is lowest among all the medications. Again, the MIC of luliconazole, the most effective antifungal agents in 2023, and you can see that again, luliconazole demonstrates the lowest MIC. Then dermatophytosis management, real world perspective. This was actually a study published by Dr. Maya Vedamurthy, who was incidentally is my classmate. And this was a very interesting publication in 2 senses. They managed to get a publication just by doing an online survey, I think. And they said that, okay, how many dermatologists? 2,000 dermatologists. 2,000 dermatologists in India is easy to get. You just send an email or WhatsApp to 2,000 dermatologists and ask them, which antifungal do you use in your practice? The answer is luliconazole. So luliconazole is the most preferred topical antifungal treatment by dermatologists in India, where we face this huge problem of multi-drug resistant, recalcitrant, and relapsing dermatophytosis. And clinical studies, of course, we do need to look at the clinical studies, look at tinea corporis, and if you see this efficacy versus clotrimazole. So of course, when you compare luliconazole and clotrimazole in open-labeled randomized comparative study, 104 patients were compared, and you gave luliconazole for 2 weeks and clotrimazole for 4 weeks, scraping for KOH and clinical cure, and this is what we found. At the end of the first week, you see the green bar, huge difference between clotrimazole and luliconazole, and you see at the end of the study that luliconazole is far superior, and you see here the comparison, that is when you look at the number of patients, especially with relapse. In other words, after completion of treatment, 4 weeks later, they were evaluated to see whether there's a relapse, and in the luliconazole group, it is much less. Conclusion, short courses, 2 weeks, once daily topical luliconazole was more effective in achieving complete clearance, faster clinical and mycological cure than a standard 4 weeks, twice daily clotrimazole with lower relapse rate. Again, comparing to terbinafine, you can see that a prospective randomized open label comparative study, 4 weeks, 2 weeks therapy, 2 weeks follow-up, 120 patients. And again, you can see first week and second week, and you see the superiority as compared to topical terbinafine. Again, one more study, a total of 20 patients with mild dermatophytosis of zoophilic origin. This is an interesting word to be used because, believe me, what is zoophilic and what is anthropophilic is very difficult to differentiate. So anyway, they called it zoophilic, and they did some studies on the animals also, 9 dogs and 4 cats and a guinea pig, and they actually used it on the skin and in the animals, and efficacy was seen. The results demonstrated significantly higher antifungal activity of luliconazole than terbinafine against dermatophytosis. Zoophilic terbinafine resistant strains, the 1% luliconazole cream, can be an alternative solution in topical therapy. So obviously, we have interesting analysis. This is a very, very interesting and important point to note, take-home point. In other words, if you look at a checkerboard of to evaluate synergistic combination of existing antifungals and recalcitrant tinea corporis and tinea cruris with squalene epoxidase gene mutation. We all know that terbinafine resistance is a huge issue nowadays. Most of, in fact, out of my 70 samples I sent, 94% of them were terbinafine resistant. And 42 patients with tinea corporis and tinea cruris who had failed oral antifungals or had relapsed within 4 weeks. And 21 isolates were identified with ITS screening that they had trichophyton mentagrophytis and trichophyton interdigital complex. And when the mutation, gene mutation was looked at, 5 isolates, 4 with a squalene epoxidase gene mutation and 1 wild type strain was noted. And you can see the MIC for luliconazole, and you can see here that there's a good synergistic action when you combine oral itraconazole with topical luliconazole. This is probably what we are going to do practically as dermatologists right now. And the synergistic interactions were noted with combinations of itraconazole and luliconazole. There is synergy with other medications also, but synergistic interactions of oral itraconazole and topical luliconazole may be clinically relevant. And this is a major take-home point. Of course, tinea pedis, you can see the efficacy data. And if you see the how effective it is, 13 tinea pedis patients found to be positive KOH. And they were actually PCR tested for ITS of ribosomal RNA, and you can see that 95% of pathogenic dermatophytes in the scales were eliminated after 4 weeks of 1% luliconazole once daily, which means it's effective in eliminating tinea pedis after 4 weeks. Tinea cruris, again, efficacy in tinea cruris when you compare with amorolfine, ceftriaconazole, and terbinafine, and you can see that 80 patients, 2020, were tested, and you can see the huge difference with 63.2% of patients with good clinical response with luliconazole as compared to the others. What do you mean by clinical response? The erythema, the itching, the scaling, everything improves, and the more number of patients on luli showed good improvement of clinical parameters, and it may be because it has an anti-fungicidal effect. Efficacy in tinea cruris as compared to clotrimazole, shorter treatment period is enough with luliconazole, and this is a study on 175 patients, and here you can see at the end of 1 week, and then again the relapse, you see the much less relapse with luliconazole as compared to clotrimazole. So of course clotrimazole has been used for a long time, but luliconazole is a newer drug which is offering more efficacy and tolerability with shorter treatment duration. Dosage and administration once daily. It is for 1 week for tinea corporis and cruris. This is the recommendation. Tinea pedis once daily for 2 weeks. All recommendations on dermatophytosis are probably no longer relevant. Almost every day it keeps changing, and probably synergistic response with oral treatment is required. We all know the rule of 2. You apply it from the periphery to the center, 1 inch outside the margin of the lesion, and then you start coming towards the center. Don't go in the reverse. Put a thin layer, and frankly 1 week for tinea corporis and cruris and 2 weeks for pedis. And of course patient counseling is very, very important. All the general measures are extremely important. Personal hygiene, clothing, adherence to general measures, compliance with treatment, and corticosteroid abuse. Actually, as dermatologists, we should actually make this a mission to try and ban any medication with a steroid combination, because this is probably the biggest problem that we are facing. And I would say that all these measures are very important, making sure that we don't keep our body wet, not wearing wet clothing, washing the clothing in 60 degrees centigrade water or higher, drying out in the sunlight, not sharing clothing or bed linen, use of synthetic and tight-fitting clothing to be avoided. Jeans is a very, very common issue. Weight loss measures in obese patients, corticosteroids in all forms to be avoided. I have a lot of patients who also used systemic. So why should we use luliconazole? A very important home point. Luliconazole is a novel topical antifungal imidazole with broad spectrum activity. We saw that. Luliconazole was shown to have the highest antifungal activity and the lowest MIC against trichophyton species currently among the currently available topical antifungals. Obviously, we need a new drug, topical drug. Luliconazole was better in achieving faster mycological and clinical cure with lower relapse than clotrimazole. This was demonstrated. Luliconazole has better compliance and treatment adherence because once daily application, short treatment duration. Faster action, lower relapse, once daily application, short course of treatment. Of course, it's the most favored topical antifungal among dermatologists, especially in the Indian subcontinent, and it helps abate mounting fungal resistance due to the commonplace use of currently available medications. And with that, thank you very much.